have been helping Storyburgh as an editor, and that's how we get connected. But I think we also share a common friend, Pamela Monk, who is our ringleader for the StoryburghLive. And probably you could also tell us about how did you meet Pam?
Yeah, sure. Pam and I met actually when I lived in State College, Pennsylvania. She was a professor at Penn State, and I had recently graduated from Penn State as an undergrad and had continued to work for the university there. And her husband was actually the dean of the College of Education, which is the college that I worked for. And so I originally met him, and then I started seeing her at some College of Education development alumni relations events. But then I also started seeing her at like Center County political events. So it's around the time of like the 2016 election, and we were both very passionate. And so we started seeing each other kind of in both contexts, and just kind of eventually started talking and became friends, realized we had a lot in common. And then, you know, she came to Pittsburgh. I was in Boston for a bit, but now when I came back to Pittsburgh, she was one of the first people I reached out to because I knew she was here and I wanted to see her again. So,
okay. So you mentioned Penn State and then Boston. So I assume you went for your master. Did you go for your master immediately after undergrad, or did you go somewhere else first?
Yeah. So I worked for 3 years for Penn State, actually doing frontline fundraising. So like development work or higher ed fundraising, whichever you want to call it. I did that for 3 years in between my undergrad and master's program. And within that time, I was also volunteering with what used to be called the Center County Women's Resource Center and is now called Center Safe. I was volunteering doing counseling for victims and survivors of domestic violence and sexual assault. And that was how I learned, you know, how much I loved counseling, and that I think I had like a particular skill set that sort of lent itself to that. And so that's why I went back to school to get my master's in human development and psychology.
So based on your experience at Penn State and volunteering, and then that's why you kind of, I need my master to do this, right?
Yeah.
So, is it like a hard decision to do that, or is it like you're really convinced that you really want to go there, right? Especially going to Harvard, you went to Harvard, right? And I bet that you must have a really good score. I don't know, does it require GRE to get there, or?
It did. I would say GRE probably played the smallest role in terms of like the components of my application, because I think like, especially for my program, like the field that I'm going into, but also Harvard's program specifically, did not necessarily value GRE score as much as they did with my undergraduate GPA and experiences, and also my essays and some other components of the application.
And after you're done with your grad, and then you went to Pittsburgh, is that where you're originally from, or were you from somewhere else?
Sort of. I'm from, I sometimes I say I'm from Pittsburgh just for simplicity's sake, but I'm actually from a small town south of Pittsburgh called Bell Vernon. So it's part of Westmoreland County. It's in a kind of a cluster of small towns called the Mon Valley. So yeah, it's not technically city of Pittsburgh, not even Allegheny County, but it's close enough, maybe like 45 minutes to get there. So
yeah, I used to live in before Pittsburgh. My family and I used to live in Pasadena. It's not LA, but it is easy to just say LA.
Yeah, easy enough.
And if you look at the map, like, wow, LA is huge, right? It's like there's so many cities, and people just say, yeah, from LA. Okay.
Yeah.
But no, actually, you live in Walnut, not LA.
Right. Yeah.
So it's something like that. And now, where do you live?
Now I live in the Southside. Yeah. So when I moved,
right here. Right?
Yep.
So that's true.
Yeah. Yeah, and I'm in the flats specifically in the Southside.
So I mean, you mean this one, right? This one, the south. There are Southside flats, and there's Southside slopes.
So I'm not sure if that's the Hot Meadow Bridge.
Hot Meadow Bridge, I think it's Southside.
It's not so bad because
This is the
Bluff
Hot Meadow Bridge.
Yeah,
I
Bluff-
live here.
Yeah, Bluff is uptown.
Yeah.
Yeah.
Okay.
Alright.
So I think I'm in the flats technically.
Yeah. But sometimes the district is like,
Yeah.
Probably.
All right. And I'm not sure. I think it's not to scale to, so who knows?
That's okay. I actually originally moved. I'm not sure where it is up there because I'm not very good with maps. But when I initially moved back during the pandemic, I moved to Greenfield, so I lived there for a little bit, and then I moved to the Southside when I started my grad program.
Okay.
Yeah.
So after you're done with your grad program, and then you came back to Pittsburgh, and then you started working for whom?
I started working for the MTA program with Presley Ridge. So it was mobile transition age youth. And I worked as a community-based therapist. So I did mobile therapy, which is when you go into people's homes and meet with folks for therapy there. It's a way to make it more accessible for the consumer or the client. And yeah, so that's what I started with. And then I did that for about a year. And then I decided I wanted to go back to school. This was actually, so that was 2 years after getting my master's degree. My first year in the field of mental health, I worked at an inpatient hospital in Boston. Then I came back to Pittsburgh, worked as a community-based therapist. And then after that, I transitioned to my current job, which I'm doing while I'm in school, working as a crisis clinician at Mercy Behavioral Health DAS program. It's diversion and acute stabilization. I'm realizing as I'm saying all this that there are so many acronyms involved with my career or life, and that might be confusing, but I'll try to explain as I can.
All right.
Yeah.
And what made you quit your job and decided to go back to school again for the second time?
Well, I really liked my job in terms of like being a therapist. But my master's degree is a master's of education. So it's not one that would be in the field of mental health licensure eligible, which is kind of a confusing thing about the field and something that I didn't really understand going into it. But if I wanted to continue being a therapist, which I did, then I would need to go on to get a license. But in order to do that, I would either have to get another master's degree or go into some kind of doctoral program in psychology. And so that was kind of like the first decision I had to make. Like, do I want to get another master's or do I want to do a doctoral program? And then I decided I wanted to do a doctoral program for a number of reasons. One of which is I could specialize in, I think what we'll talk about a little bit later, OCD. Another of which is I could do research as well as clinical practice, which was appealing to me. And so, yeah, I chose the doctoral route. Then I had to choose between a Psy.D program or a PhD program, which is also kind of a tricky decision. For me, that decision came down to a PhD program involving probably more research and less clinical practice, whereas a Psy.D program tends to be more clinical practice and less research. You still get both components in each program. It's just kind of like, how do you want to balance it? So I wanted to balance more of the clinical practice and less of the research. And so I chose Psy.D. And then I applied to Carlow, and here I am at Carlow.
All right.
Yep.
Wow. That's quite a journey. So are you in, which year are you in the PhD program? Second year, right? Or
I am in my second year, heading into my third year. Provided that I pass my comprehensive exams this summer, then I will be in my third year.
All right. And how long is the program?
It's 4 years, 3 years of coursework, and 1 year of your APA internship or your accredited internship. So theoretically, I have 1 year, but maybe 2 years, depending on how long it takes me to finish my dissertation and accrue internship hours.
Okay, so Psy.D also requires dissertation.
Yes.
Yeah. Okay, so after you get your degree, so what's next? I mean, what's the requirement before you could have your own clinic or you have your own practice? How does it work?
I do want to be in private practice, I think. I'm only halfway through the journey, I guess, so things could change, but kind of right now, that's what I see as a long-term goal. And I just forgot the question. Sorry.
So what are the requirements before you could see patients? Or you have
So I have to accrue a certain number of hours in the field practicing as a psychologist. So I could do that either via postdoc or kind of different routes to do that. I think from what I understand, it takes like multiple years, at least a year. And then I'll also have to pass a licensure exam called the EPPP. I don't know what that one stands for, so I'm not even going to try. But yeah, I'll have to pass that. And then I'll go from there.
And I realized that being licensed in one state doesn't mean that you could practice in different states, right?
Mm-hmm.
I have my own therapist, and during COVID, I think somehow, I don't know which year, I think we had to go through 3 years of COVID years, right? I think I probably in the second year or the beginning of third year, we we went to California. And my therapist said that I could still do therapist through not Zoom. I think it's Doxy.
Mm-hmm.
So I was like, oh, okay. So that's really convenient. But I just realized recently that it's no longer allowed. Because I was out of state because I think several weeks ago I went back to California. I was like, oh, okay, but still continue with a phone call. That nope, not anymore.
Yeah, I think some of that changed when the pandemic status ended.
Yeah.
I feel like the therapists and psychologists out there, if anyone is watching this, would know better than I would. But I think that changed when the pandemic status changed. I think they were trying to be more flexible to make telehealth more accessible for more people.
Right.
And then now they're kind of being more stringent with the state-by-state requirements.
So I just go back to normal.
Yeah.
Not new normal, but normal.
Yeah.
All right. So, and I remember I forgot how many years, it's like COVID, just like a block, right? I remember that you spoke in Storyburgh's event that's also held here in Point Park University at the CMI, the old space of CMI, Center for Media Innovation. You spoke about mental health, and you brought up about your experiences having OCD, right, which stands for Obsessive-Compulsive Disorder.
Mm-hmm.
All right. So I heard, also through my experience, that sometimes getting diagnosis itself is a journey. Sometimes it's not the final diagnosis. I mean, there are like multiple diagnoses before. This is it, right? Because I think. Let me just ask you. What the process before a person is said to have this diagnosis? What is the because for physical physician, right? For physician, it's like, okay, blood test, you do this, you do X-ray, you do whatever scan, and you could actually pinpoint like, okay, you have a fractured bone, and this is the recipe to fix it or whatever, right?
Mm-hmm.
But how does it work for psychology, for psychiatry?
It's a little differently, and not quite as like formulaic as maybe it could be. But you're right. Diagnosis is kind of a difficult topic to tackle as a field for a lot of reasons. Like part of that is because so many of the diagnoses are sort of created via a standard that's very much looking through like the white lens. That's just one of the problems with what we use in the United States is the DSM-5. That's like our diagnostic manual. And that's consistently being updated. So not too long ago, it was the DSM-4, and even the current version that we have, the DSM-5, was updated to still the DSM-5, but it was tweaked a little bit, and now it has like an updated name. And so that's constantly being revised. So diagnoses aren't set in stone, I guess you could say. We definitely have not arrived at all the perfect definitions for all the potential symptoms of mental health or mental illness that there could be. So that's one thing. In terms of getting a diagnosis, simply going to a therapist or a psychiatrist, or I think in some cases even a PCP can give you a diagnosis, which really just means like on your chart or on your note, they will like, reason for visiting major depressive disorder or reason for visiting generalized anxiety disorder. And there are certain diagnoses such as major depressive disorder and generalized anxiety disorder that are kind of easier to put on a piece of paper, whereas some others take a little bit more time to sort of figure out if that's really what's going on with the person or if it's something else. And so that might take a little bit more time in therapy, could take years in therapy, kind of for better or for worse. I'll talk a little bit about like my own personal experience with that. And another thing that can lend itself to diagnosis is actually something specifically that psychologists do, which is assessments. So that can be anything from like an IQ test to a personality assessment to like the Rorschach test is a really common one that folks have probably heard of. That's like a projective test. And that information that you glean from those tests, it's not going to like, you're not going to take the test and then get a diagnosis, but information that you glean from that test can help formulate a diagnosis for the clinician. And even if it doesn't sort of pinpoint one specific diagnosis, it can at least inform them of your symptoms, which would ultimately help your treatment and treatment outcomes. So yeah, diagnosis is a complicated topic, but also something that I'm kind of like passionate about and interested in, partially because of like my own experience with it. So.
Yeah, I think knowing the knowledge is one thing, but experiencing it on a daily basis is another thing. And then when you have both of them, it's, I think it's interesting. I mean, it makes it more powerful, I think, right? So it's like when, you feel it, right? And I mean, it's not just theory based on the third person's experience, but it's you yourself. Sometimes you can either validate or invalidate whether it's right or wrong. I mean, right? Mm-hmm. But you also mentioned earlier that this manual or this knowledge was based on the white lens. So that kind of perked me up a little bit. So what does it mean?
We're trying to, by we, not me personally, but in general, I care about it being improved. But the field in general is like trying to address diversity within like its diagnostic manual. And that's like everything from gender identity, sexuality, race, ethnic identity, disability status, like all sorts of factors that really just, when the history, the first DSM came out, weren't necessarily valued or considered as much as they should have been, and now I think can be. So yeah, that's kind of like, again, constantly evolving.
Would you be able to provide some examples of, the differences or the, I don't know what the word is, but insensitivity, from all this stuff that now we are considering that we have to think of, but probably in the DSM-1, they didn't, right? So is there any example that you can mention?
Kind of a common one is ODD, which is oppositional defiant disorder. It's a diagnosis for children. And basically the way the criteria are laid out, which not that I have that memorized, but one of the things that becomes hard is distinguishing between, is someone experiencing like actual pathology, or are we missing things as the clinicians who diagnose that could be aspects of that person's culture that is different from our own. So, for example, kind of like a historical trend in the field right now that I think is trying to be corrected, and I think a lot more white clinicians are becoming aware of, is that the diagnosis of ODD is often applied at far too young of an age and is way more often applied to males, and specifically Black males. And it has not historically been a helpful diagnosis either. I mean, sometimes it is, and sometimes it leads to early intervention, and that's wonderful. But other times it kind of just starts young Black boys on a path of systemic injustice that sort of spirals throughout their life. And so that's a diagnosis that, as a white clinician, I definitely have to be aware of before I offer that, because it has repercussions that go beyond like just treatment, you know?
So you're saying that everybody has a different baseline based on their culture, probably also based on, I heard this a lot, like a parental trauma, in addition to their own trauma, and probably also grandparents, and probably not firsthand experience, but things that they were told. We are always, we live always in stories, right? I mean, we remember growing up that we listen or we heard stories from our parents, from our grandparents, and sometimes we heard them during our formative years, so it's kind of in our head, right?
Yeah.
So that's why now you guys trying to figure out how does that contribute to the final diagnosis.
Right. Yeah. Kind of that like intergenerational and like vicarious trauma.
That's hard.
Yeah. Yeah. Oh my gosh. Yeah.
Yeah. But sometimes changing too, right? I mean, I know that when I'm doing my own therapy, not my own, but with my therapist, there are things that I do not say, right? Not that I don't want to say it, but it's just sometimes that it doesn't occur to me that I have to tell her about it, right? But sometimes the things that I say that may give her like wait, and then it's like trying to put it, it's like another piece of the puzzle, right? It's like okay, I think if the story is too profound, it probably may change the entire picture, right?
Yeah. So can I ask, actually, is your therapist white?
Yes.
Seriously? Okay. I'm not surprised. That's right. The majority of therapists in Pittsburgh, unfortunately.
Yes.
I mean, we need more therapists in general, but we really need more therapists of color.
Right.
So I'm going to sort of flip the table,
please.
And just ask, is there anything that you have shared with your therapist, or maybe not shared with your therapist specifically because they're white and you...
I think something recent that I told her that, in Asian culture, it's like, we grew up like saying I sir, basically, figuratively to our parents, right? You just do as you're told, otherwise you just shush, right? So it's not that they are being oppressive, but it's the culture, things that we see from our parents, but from other people's parents, from our neighbors' parents, from our friends' parents, from everybody, from the TV that we watch.
Yeah.
Right. So I was born in Indonesia, and I moved to the United States when I was it was a long time ago, when I was like 20 something. So I even remember 20. Wait a second, I was 22. Mm-hmm. So there, So so when I talked to my therapist, I had to explain, okay, that was normal. That was normal. I mean, what we do from whatever that our parents told us, that's a different thing. Whether we do it or we just say yes and then we don't do it, or we just say no to them, which is kind of rare.
Yeah.
Sometimes, you don't do that. That's not part of it's not that part of our culture to say no.
Yeah.
Even though, it's sometimes we just say yes, but we actually don't do it, right? So I don't know which one is bad, which one is worse, but
I love that you could explain that so well to your therapist. I think like that speaks to, I'm sure where you are in your own just like ability to communicate those things, and also hopefully the safe space that is it a she?
Yeah, it's a she.
That she created to sort of help you feel comfortable to share something like that. Because that doesn't always happen between like white clinicians and clients of color. And then the other thing is that some clients wouldn't necessarily have the language or be able to like express what you just expressed comfortably. And so sometimes it's easier, from what I understand, obviously, again, white clinician. I've also been a white client with, clinicians who are also white. So this is kind of like what I understand so far. But one of the issues is it's kind of like a burden to have to explain something like that. Whereas like it might be easier if someone could just sort of, understand that about your culture already, and that just be kind of one less thing that you're tasked with explaining to the person, to the clinician, I guess.
Right.
So,
and especially, I think we've been hearing a lot of, terms that I'm not comfortable. I haven't heard, or is new to me. For example, trauma, right?
Mm-hmm.
What is trauma, right? Like for the example that I just expressed, but parents, telling me things, what to do and what not. But, is that considered trauma? I don't consider that trauma. This is just like part of parental teaching, right? But, may that induce trauma in our brain? Probably. I mean, depends on the definition. What is trauma, right?
Yeah.
Right? I mean, if you think about trauma just being, like say that's a Play-Doh, right? Or Play-Doh is, if you press with a certain force and then you make a dent on the Play-Doh, does that constitute trauma? You changing the shape of a thing, of an object, right? So
Right.
I'm sure, of course, a Play-Doh is soft, but if you, it's like slam a hammer on this table and make a dent, is it an act of trauma, to the table by
Right.
slamming the hammer, right? So it's like, okay, I mean, it sounds, I don't know, right? So, and also boundaries, right? People say, okay, you have to respect my boundary. I mean, okay, but boundary is your boundary, or you are trying to, or it's like, how do you manage, I don't know. So, I mean, my understanding that boundary is something that you, as the first person trying to create fence, you build a fence around you, and that would be your boundary. But you don't raise your fence on somebody else's space, right?
Yeah.
Basically, I mean, if you do, you place your boundary in somebody else's space, that means you're restricting them. You are oppressing them because it's not your space. You can. I guess that's, I'm still struggling with boundaries. I mean, who's doing the boundary? Who's the active participant here,
Oh
right?
gosh, yeah.
And who's the recipient, right? Who's the so.
Yeah. I feel like you just brought up so much good stuff that I can talk about. And I don't know which way to go first. Well, the first thing is about trauma. I think it's really important. Yeah, so trauma is really complicated. And I think we're like just starting, or at least maybe it's simply new to my awareness and it's actually in the field not as new. But kind of the complexities of trauma and different types of trauma. But a big component that I think is really important, like when I'm working with clients, is how they perceive whatever the experience is. So like you might perceive that experience of your parents being very strict with you differently than someone else might, depending on a number of factors. And so perhaps it was a variety of trauma for you. Perhaps it wasn't for your sibling or someone else who would have experienced that.
Good point. Yes.
So yeah, definitely not an expert on trauma, but I think that's kind of like an important aspect to working with clients who experience trauma that I try to bring to our sessions. I also loved your visuals of like the clay, because I think that, yeah, because that, brought up a lot of thoughts for me in terms of like, well, what is it, what is it being pounded on? What is it being pounded with? What kind of wood is it? Is it plastic? Is it glass? Like, and that kind of being another analogy for how that action is perceived. In terms of boundaries, also appreciated the analogy of fences. I think that also is like a really complicated topic that is both trauma and boundaries. That's kind of like in the forefront of like popular psychology or like mainstream psychology. Like you see a lot about trauma and boundaries, and narcissism is another one that you'll see a lot like on TikTok or Instagram or social media. And so I don't know, they seem to be like sort of like buzzwords. And on one hand, it's really important that there's psychoeducation entering sort of the mainstream around these topics. On the other hand, I think there's also a lot of misinformation, and some of it's getting misconstrued, and that's not the best either. So yeah, that's my 2 cents. I'll leave it there.
Awesome. Yeah. So there's a topic that I'm going to get there later on, which is fascinating to me. I mean, I'm just gonna say it now. For the social media, for the TikTok, Instagram, I've been using Instagram solely for those for those ADHD channels. I don't know, ADHD. There's so many of them. I don't know. Probably is just their analytic, just like algorithm, like identifying me, being a sucker on those videos. They keep on sending me variety of influencers. But I learn a lot. I mean, always though, I keep in my mind that just learn, but not necessarily take it as a truth. But you just have to balance. Probably if there are a lot of them and they sound credible, then probably it's true. But probably you just have to figure out some more, or just put a check mark to it. All right. And so, what do you think about those TikTok Instagrammers? Facebook Reels. Is it helpful, or is it shunned upon in your field?
Well, I probably can't answer for the entire field.
Right.
And I also, I have mixed feelings about it. On one hand, like I was a teenager / young adult who didn't know anything about mental health or mental illness or, the symptoms to look out for. And I was lucky that I was in a place at the time of sort of the highest acuity of my symptoms where I had access to support. And I'm lucky for other reasons too, like that I've learned along the way, like having a family support, having an education, my socioeconomic status, my whiteness, there are all sorts of privileges that play into that. And so on one hand, I'm like super passionate about making like information and resources about mental health and mental illness as accessible as possible to as many people as possible. I think there are 2 really important things that does: psychoeducation, which can be quite preventative, and then also reducing shame, to like let people know that whatever they are experiencing that maybe they think is just absolutely bananas is actually not that like unique to them. Other people experience it, and there's a word for it, and there's a whole language around it. So I think those are kind of the helpful things. Some of the unhelpful things then are, like you said, like some of the sort of misinformation is not helpful. You have to sort of be, what's the word, like a critical consumer of whatever media you take in, I think, just like you would like journalism. So be sort of cautious, I guess, is like this would be like my advice. But again, this is coming from, this is just how me as a 30-year-old kind of processes that information myself. I kind of am critical and wary of it, and sort of, I guess, hesitant to just like jump right in and believe something that I see on TikTok until I've researched it further. Same with Instagram. And then, you know, at the same time, I'm 30 and some of the people I follow on Instagram have been so helpful in my own recovery. I've learned a lot that way. So, right, I see kind of like both sides of it, I guess.
I think one thing that I think is totally beneficial is because there are so many of them, it kind of destigmatizes the feeling of having whatever diagnosis, right? Because for me, for example, of the ADHD and anxiety or something, right? So it's so common that that it's okay. I mean, everybody is experiencing it, and you don't have to be shy about it. And I know I have a teenager, and she and her friends, you know, they share, you know, they kind of like, what do you have? What do you have? It's like, you know, like exchanging Pokemon card or something.
Yeah.
It's like you know, knowing each other's diagnosis or not, right? So it's like cool. I mean, right? So I mean, people are not shy anymore, right? Or if they have one, they're kind of like, so what? I mean, right?
Yeah.
I'm sure you have something, you know, so you just don't know it yet, right?
The caveat that I will say to that is I think that's true in a lot of places and in a lot of environments, but I don't think that is true everywhere, especially in like more rural environments, for example, like places with less access to education, you know, less internet access, things like that. So while I do think that is more common and more so the norm, I don't think it's the norm everywhere necessarily. So, yeah.
All right. So let's talk about your own symptoms. You know, you mentioned about OCD. I mean, I think I have used that term OCD probably jokingly to, you know, to my family members if they are too intense on doing something, like, oh, you must be. But let's hear it clinically. So what is it? You know, what are the manifestations of this OCD?
Yeah. Well, first, I'll just say for anyone who's even considering using that term colloquially, please don't.
Okay, sorry.
No, it's okay. It can be, you know, I think for me personally, I'm at a point where it's like, okay, I hear that and I'm just like, whatever, I'm not that sensitive to it anymore. But for a lot of people, if you are in the throes of OCD and like really suffering from it, it can be just really frustrating to hear it kind of thrown around as like something that's funny or like a positive quality, like something that makes you really neat or clean. And the other thing that does actually is sort of funnels OCD into this one definition, which makes it harder then for people to get the care that they need. So like my OCD is not centered around cleaning or like neatness or kind of the stereotypical presentations that you might see. And so I do think that's also part of why it took a while for me to get a diagnosis. But going back to the diagnosis itself, so OCD is characterized by obsessions and compulsions. Obsessions can be inward and outward. Compulsions can be inward and outward, meaning you might see them, you might not. They could be internal mental compulsions. The obsession is typically driven by some sort of fear, a feared stimulus. And then the compulsion is driven by a need to or a desire to eradicate the fear or fix the problem or no longer feel the discomfort. So an example of that is I might get it into my head that this table is contaminated, and if I touch it, I will contract a virus that will kill me and my family. So I compulse by avoiding this table. I will not touch it. And then compulsions have a tendency to sort of exacerbate. So it might start with like, okay, I cannot touch the table. But then eventually it might be like, well, I can't even look at the table. So now I can't look at the table. Now I'm like really restricted and really awkward. And so it kind of like escalates and builds up itself. It's like the more you compulse, kind of stronger it gets, the harder it gets, and the more restricted you become. So a lot of people with OCD have had the experience, unfortunately, of being like confined to their room or confined to their bed or, for periods of time because so many things around them contained these sort of like feared stimuli that they like couldn't leave their immediate vicinity for fear of XYZ happening. So it can become really debilitating. It often goes hand in hand with depression because, if you think about it, if you're staying in bed because you're scared of different things around you for different reasons, you're probably pretty isolated, among other things. So depression, unfortunately, can go hand in hand with OCD as well.
Okay. So for your own manifestations, what are they?
Yeah.
Because I think you mentioned in that talk that we had at CMI, right? And I think you mentioned that even your OCD kind of helped you in your study, right?
Yeah. Yeah. So we talk about OCD, obsessions and compulsions in terms of themes. So my sort of themes are perfectionism, which is what I talked about in that event, and how that manifested for me as a student throughout the years, and how that's probably part of why I ended up going to Harvard was because I had this compulsion to perfect, which in my head was to get straight A's and a 4.0 every single semester. So I sacrificed anything and everything to get that 4.0. That eventually led to me also being quite sick, but, also led to me going to Harvard. So who knows if without the OCD, right? No way to know. I don't like to think that it's my OCD that's not why I went to Harvard. I like to think it's a whole bunch of other things. But in reality, I have to acknowledge that that obsession and compulsion played a role, or could have played a role. What was the other part of your question? I'm sorry,
I think
forgot.
I think that's great that you acknowledge that, right now, just like in my brain, it's like, I like to say that anything is negative, sometimes it's also positive.
Yeah.
Right. I mean, it has two sides of a coin, right? So anything can be positive, anything negative. And, but I like to say that, getting into that diagnosis, I could see the difficulty of getting that diagnosis because when you mentioned about, your intensity to study to make sure you get 4.0, it could also be, I don't know, like a hyper focus, right? For people with ADHD, when they're hyper focused, they could get things done quickly, perfectly when they're in it, right?
Yeah.
And we also notice, I think from some autistic people, right? They also have that characteristic of, when they're in it too, they get, they just stay by themselves and then they tinker or they study and they work on it and then they get it done better than anybody else could, right? So I my brain, when you mentioned it, but wow, it could be anything, right? It's so hard. That's why you can just, okay, let's do CAT scan and then you'll figure out, okay, here it is, right?
Yeah.
So it could be so many paths, so many branches until you could see, okay, here it is.
I'm so glad you said that, and you said it so well. But yeah, that goes back to the diagnosis thing that we were talking about. That's part of why, you see those symptoms and they could mean a number of different diagnoses, or they could indicate a number of different diagnoses, but it takes time to sort of figure out what's going on beneath those symptoms in order to ascertain which diagnosis is most appropriate and which one is going to lead to the most appropriate treatment for you. So yeah, I'm so glad you said that because that was, very well said.
So I guess it's like, when we watch, or when I watch all these Instagrams or...
So clearly that's been beneficial for you.
That's right. But this is just a part of the pieces, that many pieces. That doesn't mean that, one is it or not, because it's just one of it, right? So there are the entire pictures, I mean, there are a lot of I don't know, check marks, you have this, you have this, you have this. I don't know how. I remember, I don't know what they call it. I think it's a Vanderbilt forms, right? That have to be filled out. I don't know. And then the teachers have to fill it out. The parents have to fill it out. And then somebody else has to fill it out. And they combine them. And then they give you a score or whatever. And instead they give you diagnosis, right? So there's so many things that have to be, calculated or thought through before a diagnosis is given. So so it's not as simple as a 30-second TikTok, movie.
Right. Yeah.
clip, right?
Yeah. So for me, one of the ways to distinguish the perfectionism was I had a lot of obsessive fears behind the compulsion to perfect, or the compulsion to, again, in my eyes, perfection was getting straight A's and getting a 4.0. And there were fears behind that. Like I had the fear that I think it started out that I was going to lose my scholarship support. And then it kind of like gravitated from there. The more I fed the compulsion, the more that fear grew. And it got to the point where it was like, I'm going to lose my scholarship. I'm going to have to drop out of college. I'm never going to get a job. I'm never going to be able to do anything as an adult, basically. And then eventually it got to the point where I was like, there is no life after college, which, is
doomsday.
Yes. So yeah, that was part of, I think, how you can sort of untangle the specifics of mine. I'll also say, just again, kind of this is for the sake of psychoeducation, I think, because I have some other themes that aren't necessarily like mainstream, such as harm, moral scrupulosity, which I'm just sort of trying to understand. And then a big one for me, and probably the most predominant theme for me, is actually relationship OCD. And so I think I presented pretty strongly with that, and that being less well known as a theme of OCD, I think is also part of what took a while to sort of get my diagnosis. So I just wanted to throw that out there for the sake of being educational.
Yeah, there's so many, not just bullet points, but sub bullets that you have to think about, or, you and the therapist have to think about it. So how did you decide that, okay, I need to see someone?
So I was in my senior year of college and my senior year of undergrad at Penn State. And like I said, that my obsessions and compulsions had kind of escalated to the extent that I was compulsing all the time and never really feeling like I could achieve perfection. I was also having, as a result of the anxiety surrounding the obsessions and compulsions, a lot of panic attacks, which for anyone who has experienced those, that can be really debilitating, like on your body. So I was like physically exhausted. I was sacrificing eating and sleeping, like was barely eating, barely sleeping in order to achieve my compulsion to get a 4.0 and to get A's on everything. Because that was another thing. It was like every little assignment. And then it became, if I didn't get, 10 out of 10 on every little assignment, it was, so you can imagine how that can sort of spiral and be all consuming. And it was for me. And so what came along with that and the panic attacks that I was experiencing was then depression. And like I said, I started to not be able to see beyond college and think that there wasn't going to be anything beyond college for me. And I started to think maybe there shouldn't be anything beyond college for me. And so I was in the realm of what we call suicidal ideation. And that actually really scared me. I didn't have that language. I didn't have language for any of it. I didn't have language for panic attacks, depression, like obsessions, compulsions, like none of that. So all this was also happening to me, and I had no way to ask for help or even know that something was this seriously wrong. So I ended up, I had a very supportive friend group at the time. And I had talked to one of those people about this, like what I now know is like suicidal ideation. And he suggested that perhaps I should get some help. I ended up seeing a counselor at Penn State's counseling center, but you could only do that for, I don't know what the number of sessions was, but it was like maybe like 4 or 5. So I did that, and then still like, wasn't feeling really better at all. The same things were kind of happening. And so one morning, after a night of like no sleep and a lot of compulsing and a couple panic attacks, like within that one night, I was really struggling with the suicidal ideation, and my friend helped me, sort of supported me to call like a crisis clinician who could come into my apartment at the time and do like an assessment, like a crisis assessment. And so that person came and shared that, I didn't have to and I wouldn't be forced to, but their sort of recommendation at that time was that I go to an inpatient hospital. And I didn't know that you could go in, like, again, I didn't have the language. I didn't know what was going on. And so I was kind of like at the mercy of the expert. And so I did go inpatient for about a week. This was like maybe like a half hour from State College. So State College didn't have like a ton of inpatient options for psychiatric care in the area, but this was apparently one that was like accessible, took my insurance. So that's where I went. That was when I was diagnosed with major depressive disorder and at the time generalized anxiety disorder. And that's kind of what started me on the path of like, after I got out of the hospital, I started outpatient therapy. I started seeing a psychiatrist once a week. And so that kind of started the journey of like regular therapy and processing, eventually finding the diagnosis of OCD and also medication management via psychiatry. So kind of figuring out which medications worked for me. And that process took years, but it kind of all started with this, experience at Penn State, which again, I'm lucky and grateful that I had the support that I had and the resources that I had when that happened, because not everybody does. And it could have, a lot of different things could have happened. So
thank you for sharing. Yeah. That's pretty traumatic. Yeah.
Well,
circle back to the topic that I mentioned. I could see that your own experience, has been leading you to this point that you decide, okay, probably somehow you kind of feel that you want to help people who may be experiencing things that you have experienced in the past, and you want to help them, right? Usually all these kind of profound experiences it's a life-changing moment, I can say, right? And I think that could totally be it, right?
Yeah. I heard this, I was at a conference this past week, specifically an OCD conference, and I heard this like gem that I want to share because I think it's relevant, which is that, so there's a lot of discussion around like identity and mental illness and how it can be really harmful to sort of identify with your mental illness or as your mental illness, but also it can be helpful to accept your illness as a part of you, especially if it's sort of chronic the way that OCD is, or it's not for sure, but likely I'm going to have this, my whole life to varying degrees. But so something that, I've worked on is kind of accepting OCD as a part of me, but just a small part. And then also, liking who I am. That's a big part of treatment too. But anyway, the thing I really liked is someone said, people talk about how like a negative thing that happened in your life can be a positive, such as like having OCD can actually lead to a lot of positive outcomes. But then I heard someone else reframe it and say, like, it's actually, if you've recovered from OCD, if you're in recovery from OCD, like that is what leads to the positive outcomes. So it's not, OCD that is our superpower. It's our recovery from OCD that can then be a superpower that we, carry forward. So I thought that was like a really important gem, and it just personally like meant a lot to me, and so sharing that as well.
Right. So I think being active, right? Being the active participant, right? As opposed to you just succumb to the diagnosis or to the situation.
Yeah.
And now you're actively doing something about it that leads you to this, right?
Yes. Yeah.
Yeah. And also, I think again, when you're telling me that, that's like I remember about the idea, or when you mentioned about perception, right? It's really about not just about, but one of it is like, how do you perceive that, right? It could be negative, it could be positive, and what you're going to do about it. So, did you have fun in the conference?
I did. Yeah, I loved it. Yeah, it was an interesting group because it was like you could attend if you were an individual with OCD, but it was also like a professional conference, so you could attend if you were a student or a mental health professional or a researcher, and so it was cool because I kind of like wore different hats, and there were different presentations focused on different topics that I could attend as, someone interested in research, someone interested in clinical practice, and also someone who has OCD. So yeah, it was a really cool experience. Yeah.
Were there a lot of people telling their own stories?
There were quite a lot,
awesome.
Which is always helpful, and again, shame reducing. So
that's right.
Yeah.
And so, what do you do for fun? I mean, after all this heavy talk, it's quite heavy.
Yeah.
So what do you do for fun?
So, okay, I run. That's the obvious answer.
Right, so before I continue, okay.
Yes.
Run.
Yeah.
Okay. When did you start running? Because I have my brain. I told my family this. My problem is that when people mention something, I try to synchronize it. Where is it in the timeline? So where does it fit, right? So you mentioned about running. So when did you start running?
I was like just sharing this at the conference because I've been running for a long time. I started running, I guess, in high school. I was in track. And then I just kind of like ran here and there through college. Like I wasn't training or anything. I was just kind of like doing it to keep up with it and to have fun, I guess. And it wasn't until around the same time that I got my OCD diagnosis, which was like 2018, 2019, that I really started training. So it kind of went like hand in hand with like my recovery, so to speak. And I feel like I've learned a lot like in tandem, like in parallel between running and recovery from OCD. I should also say, before we talk about all the fun stuff, again, for educational purposes, that OCD is one of the unique disorders in that it has a treatment for it that doesn't work for everybody, but is quite empirically backed and does work for a lot of people. And so if you have OCD and you're suffering, it is worth exploring. It's called exposure and response prevention therapy. That is what I eventually found. And I say, not to be like dramatic, but I say like what eventually saved my life. And I think what I really mean by that is it like gave me my life back. Like it helped me take control of my own life as opposed to OCD having control. And so I just want to throw that out there, before we talk about the fun stuff, just in case there's anyone out there suffering ERP, just look it up and go from there.
And find a therapist first.
Yes. Yeah.
Yeah. So I think, I saw about that ERP. So is it basically like what is it called? Control treatment? Is it like you expose yourself to the triggers and then you try to manage it as you're responding to it?
Yes.
Is that how it works?
It is. And if that seems terrifying, it is, but also it's...
So you have to do it with somebody else in the room, right? So you can't do it on your own.
And you build up to it. So it starts with like very, very small things. And so on the outset, it sounds like it's very scary, which can be a sort of a barrier to treatment. But in reality, if you're actually participating, the clinician knows to kind of like start things off very small. And, the clinician just is a very good support throughout the process. So it actually ends up being less scary than it seems and way more strengthening. Like ever since I started ERP and running, again, it goes hand in hand. I feel like way more of a badass because like, you know, I can run for really long periods of time, but I can also like face my fears head on and, you know, choose to still live my life as opposed to let the fear overcome me. And so it's a very powerful therapy in a number of ways.
Right. And the running, I heard it helps like regulating your mental in addition to your physical regulation, right?
Yeah.
So how does it work? Does it like induce some kind of chemical or hormone in your body?
Yeah.
How does it work? You know.
I don't know if I can really answer that question. I feel like I'm not qualified to.
Okay.
I know it makes me feel good. I know.
It's like I heard that, you know, I guess thanks to the Instagram and TikTok, you know,
Yeah.
like people mention about meditation, right? People mention about being active, right?
Yeah.
And people mention about you know, I forgot. Oh, diet, right? So
Yeah.
do those things apply to your condition, or is it only for?
Yeah, I think there's all kinds of avenues that you can look at. So I think exercise helps. Again, me, I think everyone's path to recovery is unique, but for me, exercise helps. And there's also research to back that up, right? Like endorphins are good at mitigating depression or helping to mitigate depression. And so that's something. There's all sorts of research coming out now, and it's kind of also constantly evolving in terms of like the connection between the gut and the brain. And so that relates to like the nutrition that you put in your body and how that might impact your mental health. What was the other one you mentioned? Meditation. I'm not sure what I was going to say about that, but yeah. But there are different, I guess, different things that you can try that can all contribute in small ways to recovery.
Okay. All right. So can we talk about the fun
stuff now? Yeah, let's talk about fun stuff. I'm ready.
Yeah. Right. Thank you about that. Yeah, I completely forgot about that. Yeah. So what do you do for fun?
Okay, so running.
Yes.
I also have the sweetest little dog named Linus. And he is an emotional support animal. I've had him since I was 23, so since I kind of started on this whole journey. And he's the best. We snuggle, we watch TV together, we read together, we go on walks, we go to the dog park, and so hanging out with Linus is some quality self-care / fun time. I spend a lot of time with family and friends. That's one of the reasons I'm back in Pittsburgh. One of the reasons I came back during the pandemic, because I really missed them and that was important to me. I also read. I do yoga. And then that's probably all for now, because honestly, I'm spending a lot of time like studying and working with clients and doing that kind of stuff. But yeah, there are some fun things going on, I promise.
Awesome. Do you have any last message to our audience or things that, because I guess, I don't want to say thanks to COVID, but, because of COVID, people are more in tune or trying to be in tune with their emotion, with their mental condition or their mental situation at that particular moment. So is there anything that you like to say to them, like to say to us,
Oh, that feels so big. That feels so big. I guess I want to say just reach out to someone and be resilient with it, because you might reach out to someone and it might not be what you think. But if you are in a place that is really dark and difficult, reaching out is the first step, and there is a path out of that. I think when I was in that darkest time, and when I've been in sort of some other dark times, it's hard to see beyond that. And so I think an important message is, if you're in that position, that there definitely is something beyond that. There is absolutely potential for more than just that darkness. So reaching out is the first step, whether that's someone on Instagram or, texting someone or someone you see in the streets of Pittsburgh.
Right.
Yeah.
So I think I think I agree with that. I think that that's the key. Knowing that finding therapists these days are so hard. So I guess reaching out to friends, people that care for you. I think
psychologytoday.com is another one. If you can look that up, and Google resources in your area. Google's definitely a friend when it comes to mental health resources. So don't give up on it.
All right.
Yeah.
Thank you for sharing a lot of good information and also sharing your own experience. We learn a lot, and very sure that people find them really useful for their own conditions.
Thank you for facilitating.